So I'm going to go ahead and talk to you a little bit about what else can go wrong with your pouch. Let's see how this works. You point to that. All right, very good. So we're talking about an ilioanal pouch with a diverting ileostomy, and I want to echo what Dr. Fazio said. If you don't do a lot of these things, do not do an ilioanal pull-through without an ileostomy. And nobody likes to have a nightmare of that sort. And we all, after a while, like to get a good night's sleep. We don't want to worry about our patients. So can we make a pouch? That's number one question. And will the pouch reach? Thank you, Dr. Fazio. And is there too much tension? And that's possible. So the question is, can we make a pouch? And it's rare that we cannot make a pouch. The only time that there is a problem is we have retroperitoneal desmoids in familial adenomatous polyposis that would not allow us to really fold the small bowel comfortably. And if you go higher and higher, then you're going to make not an ileal pouch, but a jejunal pouch. And that is not, of course, appropriate. And sometimes it's a very edematous and fatty mesentery, which is rare because, as Dr. Fazio mentioned, it's the colonic pouch that's difficult to make. In the small bowel pouch, it should be much, much easier. If that happens at all, then we can resort to an edge pouch, which was created by Dr. Funkelsrud in children. And that, because it's a small one limb coming down to the anus, it's a little bit difficult to construct. Trying to go back. Let's see. Well, it's not going back. All right, here we go. Anytime this works, I believe there is God. So, now, how about a leak-proof pouch? You want to make sure that the pouch is not bleeding. Irrigate it before you close the pouch. Check the pouch for a leak. Distend it with betadine or something like that. It's easy to see a leak of brown stuff. At the tip of the pouch, if you have gone the way Dr. Delaney showed, from the tip up with a 10 centimeter linear stapler, be careful with that tip. That very tip might be a bit ischemic. And then check for leak and, of course, do the proximal diversion. And the way you check leaks is that you inject air after you have connected the pouch and look for air bubbles. This is what we learned from the mechanics when they repaired the tires. And we do this very scientifically. So what is the problem with the pouch reaching? The main issue is the superior mesenteric artery length. And the contributing factor is gender. It's more difficult in men because the pelvis is narrow and the anal canal is long. There could be a stocky fat habitus. I'm sure Dr. Fazio would not want to do an ileal pouch anal anastomosis on me. He wants to do it on skinny people. Prior operations, patients who have had an abdominal colectomy, let's say for toxic megacolon, and you come back to do a pouch operation, they have a lot of inflammation, etc. And I think that it is best for those patients who have had an abdominal colectomy to wait at least 6 months, allow some of that abdominal inflammation and stuff settle down before you come and do this procedure. History of peritonitis and abscess. If a patient had a perforation, let's say during a colonoscopy, and developed a peritonitis, and it looks like an abdomen after trauma, and which is a trauma. You know, colonoscopic perforation is a trauma. And finally, patients who have desmoid in familial polyposis. Now, for many of us who don't do these operations long, there are two recommendations. One, do not divide the ileocolic artery. You may need that. You may need that for the pouch to come down. So we are so comfortable with cancer operation. When you do a right hemicolectomy, you take the ileocolic right next to the superior mesenteric. With one tie, you're done. If you come around the cecum and you take the multiple vessels, it takes a longer time. And if you want to do it quickly, and you take the ileocolic vessel at the second time, or at the same time when you want to make the pouch, you may find out that the superior mesenteric is tethered, and you may want to use the ileocolic for length. And the second one is if you are doing an operation that you're going to come back as a second stage, do not mobilize the rectum. It just makes it much more difficult. There is no reason to cut the rectum behind the prostate. I don't see any benefit from that. You cut the rectum at the level of promontory because at the second stage, you're going to take that out anyway. The same recommendation for diverticulitis. There is no diverticulitis of the rectum. So if you're going to divide the bowel somewhere, divide it at the level of promontory, so when you come back to put the bowel back together, you don't have to struggle trying to fish out the rectum from the bottom of the pelvis with all of those maneuvers that Dr. Fazio mentioned about the reoperative pelvic surgery. So if you want to, okay, well, I tried all three buttons. If you want to divide this, divide the vessels outside the ileocolic so that you do not sacrifice the ileocolic artery. You want that. Now, what about getting the pouch down to the anus? You choose the proper length, and it seems like 20 centimeter pouch is about the place where the apex comes down the lowest. You completely mobilize the small bowel to the duodenum. Dr. Delaney did laparoscopically that it was free and hanging from the duodenum all the way to the anus, if you may. Score the mesentery. It's a little bit tricky because you might get into the vessels, but hydrodissection that's described by Dr. Fazio is a great idea. You infiltrate a little bit of saline, and now you can safely cut it. You kind of score that thing. I don't believe that that helps very much at all. But the double stapling technique allows you to go a little bit higher at the anus. One of the problems is now double stapling has allowed surgeons to cheat. So sometimes the patient comes back thinking they have pouchitis. You do a flexible sigmoidoscopy, and you find out that there's 6, 7, 8 centimeters of rectum left. And that's because the double stapling were done at the midrectal level rather than at the top of the anal canal. So Dr. Fazio said, divide the bowel about 3 centimeters from the anal verge, and that would be just maybe about 1 centimeter above the dentate line, and that's fine. You go much above that, you're going to have a problem of persistent symptoms from ulcerative colitis, or worse yet, retained polyps in familial polyposis. So here's the pouch being made from the apex back, and that is the area that will become ischemic. You have to be careful, and if there's any question about it, you can just trim that edge. Now, stripping was something that was done a long time ago when this whole business started. When we started doing this in 1980-81, we always did mucosal stripping. But it kind of faded because the functional results were not as good. There were arguments made between Cleveland Clinic and Mayo Clinic, and of course Chicago is stuck between the two of them. So sometimes you pray to the Mecca northwest, east, and sometimes you pray to the Mecca to your east. And so what we did, we waited till these two groups stopped fighting, and then the ultimate result was we do a double stapling and don't strip the mucosa. It's not important, and it actually makes it very difficult to sometimes to reach. 2 to 3 centimeters makes a great deal of difference if you don't strip it. So, and then the rest is simple. You can see you have left a very short rectal stump to do your anastomosis. So, is there too much tension? Well, you have to completely mobilize it, do adhesiolysis, do the vascular division. Now, I'm not so bad about dividing superior mesenteric artery. Our institution does a lot of small bowel transplant. So my job is to harvest the small bowel. And the way we do it is we divide the SMA just beyond the jejunal branches so that we can take the distal 180 centimeter of the bowel for transplantation. So in this case, every donor has their superior mesenteric artery divided. That is a must because that's what is used for transplantation. So I'm not worried about it. I do it virtually every small bowel transplant that we do, so that I figure, well, I can do the same thing, if you may, on the patients who are getting ileal pouch anal anastomosis. I have only heard of one case in southern Illinois that this window of the mesentery that was left open allowed the small bowel to herniate, volvulize, and the patient ended up losing about 80% of her small bowel because of the volvulus and an internal herniation. So if you're making a window there, it would be nice to close that window, close the mesentery. And if you don't have enough tissue, you can bring the omentum and put a patch to close that window. So here's the stretch. As you can see, the major problem is the SMA. And you can, after the jejunal branches are gone, you can divide the SMA. And yes, you rely on the retrograde circulation from the ileocolic vessel. But I'm not so worried about that. But remember, you create a window there, and that window can produce or contribute to internal herniation. There are some people who talk about doing progressive ligation, allowing the bowel to hang down. I am not that brave. And I do not want to do something that terminal small bowel would start to look dusky, and you lose a huge amount of small bowel with attended malabsorption. And so you can, if you have a hard time for the bowel to reach, do an H pouch. I'd much rather do this than an S pouch because it's easier to do. You bring in the distal limb, you divide it and make the proximal one right next to it. This is the Funkel's-Ruth operation, what was done in children at the University of California. So after everything is done, it still won't come. What we have done, and we have published this, is that construct the pouch and leave it in the pelvis. Now, Fazio showed you can suture it there. You can suture it if you wish. But then you leave it and do a proximal ileostomy and leave it there for 4 to 6 months. After 4 to 6 months, when you come back in the abdomen, that pouch almost looks like an American football. It's a good size thing because of secretions having stagnated into it. And so it's no problem, not only because of size, but also because of the stretching of the SMA, and now it will reach the anus very easily. One of the problems is that if you have done your colectomy all the way down to the anal canal and leave this pouch in, it's very difficult to find that distal end. You're going to be, especially in a male, you're going to have a problem because the prostate and the seminal vesicles fall backwards on the hollow of the sacrum, makes it enormously difficult to dissect those out without injuring the urinary tract. So if you're not sure it's going to reach, leave the rectum in and come back at the second stage to take out the rest of the rectum and do the pouch anal anastomosis. So pouch-related problems is bleeding. If a patient following your pouch operation bleeds the next day, check the coagulation profile, because there's always some issues with coagulation in patients with IBD. Most often they're hypercoagulable, not hypocoagulable. But you can find out if it's in the pelvis or it's in the anus. If it's the anus, it's the pouch. You evacuate it, endoscope, find out maybe there is a pulsatile bleeding in one of your staple lines. That's the case, you can coagulate that very nicely. If it is coming from the pelvis and the patient is leaking the blood from the ileal anastomosis. Then you're going to transfuse and monitor. If it stops, fine. If not, you may have to operate because clots absorb and eat up platelets. So if you leave the clots in the pelvis, your platelet count will go down as well. I think I better stop here because I have a lot more slides and I don't want to punish you with that. But there is an issue sometimes you do an ileal pouch anastomosis and the patient can't eat. And those are very thin, skinny patients that the pull of the superior mesenteric artery over the third portion of the duodenum causes what they call the SMA syndrome. And so it is a problem of patients. And you can do an upper GI study and you can see the interruption of the contrast at the level of the third portion of the duodenum. And then you can either feed them prone or give them hyperalimentation. And these are usually people who are very, very skinny. And the pull of the superior mesenteric artery almost occludes the third portion of the duodenum like a band. Thank you very much for the opportunity of sharing this.